Good evening and welcome this evening to the 2020 Meningococcal webinar hosted by the Immunisation Coalition. My name's Susie Blackburn, working for the Immunisation Coalition, and our mission is to advocate for immunisation to protect Australians against infectious disease. Thanks so much for tuning in this evening. We're expecting a busy evening, so we'll get straight into it. Please, if you'd like to ask questions, use the Q&A tab on the bottom of your screen. You may have some questions that are unanswered at the end of the session. That's fine. If you'd like to email that through to us at the Immunisation Coalition, we can follow up after the event. If you are listening in groups this evening, you may have just registered under one person's name. If all of those other people in the group would like a professional development certificate, we'll also need you to email the Immunisation Coalition. I'll give you more information at the end of the session. So our presenter this evening is Angela Newbound from the Adelaide Public Health Network. Angela is a highly respected public health expert and Immunisation Coalition member. Thank you and welcome to you, Angela.
Thank you very much, Susie. Good to be here.
I hope you're keeping well over there in SA, in South Australia.
I think we're leading the country. We've had no COVID cases now this is day 7, so fingers crossed we've done very, very well.
Such great news, and hoping it moves forward in a really positive way for you.
For sure, for sure. Okay, so we shall get started. If you are not here for a meningococcal webinar, then you better hang up now. But this is what we are going to be talking about for the next hour. So we do have quite a lot of information to give to you, but certainly please use the chat box and put lots of questions forward. Susie will monitor those and will interrupt me along the way if there are some questions that need to be answered. So I think most of you would probably know meningococcal disease really, really quite well. It is an organism of humans, so we are the only natural host for this particular bacteria. The bacteria normally will colonise in the upper respiratory tract, and it usually doesn't cause any disease. So this carriage, I suppose, is when it sits there for a period of time, and that prevalence seems to be fairly stable, that it's estimated to be around about 21 months that people will carry this bacteria quite harmlessly in most cases. And that could be anywhere between 3 and 25% of the population. Very much depends on age. It does seem to be a problem in some particular age groups, and we'll be going through those as well. But it's quite interesting that the asymptomatic carriers of meningococci are very unlikely to develop invasive meningococcal disease. But we certainly know for some individuals it is an invasive disease and a very, very serious disease. Transmission from symptomatic cases is uncommon. The vast majority of cases are really quite sporadic, with transmission assumed to have occurred from a prolonged close contact with an asymptomatic carrier in the network of close contacts. So you do need to have really close contact with somebody for this disease. It doesn't live well outside of the body. It dies fairly quickly on surfaces. It's often described as a kidney or a coffee bean shaped bacteria. So the strains that cause invasive disease are ones that you need to isolate them from normally sterile sites such as blood or cerebrospinal fluid. So the different serotypes, and we'll talk about these strains of A, B, C, W and Y, although we do know there's around about 13 known serotypes, but certainly A, B, C, W and Y are the most common that are seen. And those particular serotypes are really distinguished by the differences of the the sugary protein coating that's on the outer membrane capsule of the bacteria. So of those more common strains, you can see over the years that the strains have bounced around a little bit. Meningococcal B tends to have held on as the most strain that are notified in B. But you can see that there has been an increase, particularly in W. Y has bounced around a little bit, up and down. But bearing in mind we are, over the last decade, a lot more aware of meningococcal disease. We've got more testing that's being done for people that are symptomatic, etc. But really interesting to have watched the way Men-B has become quite a significant strain. Meningococcal C, we really very rarely see cases of meningococcal C since we introduced the meningococcal C vaccination program onto the funded schedule in 2003. So this has been an exceptionally good vaccination program. Meningococcal A, we don't see a lot of Men A in Australia, but certainly if people are travelling overseas, or particularly to sub-Saharan Africa, if you've got pilgrims going to the Hajj, then it would be certainly a requirement for them to be vaccinated with an ACWY vaccine in order to be covered against that particular strain. So an update of this year's cases. As of the 26th of April, there's been 38 invasive meningococcal disease cases reported to the National Notifiable Disease Surveillance System. Spread out really across the country. Northern Territory has had no reported cases up to the 26th of April, but only 1 in ACT, 8 in New South Wales, 16 in Queensland, only 2 in South Australia, 2 in Tasmania, 6 in Victoria, and 3 in WA up until the 6th of March. Last year, there was a total of 206 cases of invasive meningococcal disease that were reported across Australia. So people will spread meningococcal bacteria to other people by sharing respiratory and throat secretions. So saliva or spit, however, it does take close and lengthy contact. So somebody does need to be very close for that bacteria to actually spread. And they do talk about deep kissing. If you just kiss somebody on the lips or you drink out of their drink bottle, it's not considered to really be a risky thing to do. But what they describe as deep kissing, so playing tonsil hockey with people is probably just not a good idea. So we know that this bacteria is certainly not as contagious as other pathogens, such as your common cold or the flu. So people don't generally catch meningococcal disease just through casual contact or breathing in the air. That just doesn't seem to happen. So signs and symptoms, really, really important that these are recognised very, very early. Disease may present differently. Generally, septicemia or meningitis. Interestingly, with Men-W, it is seen more so that sepsis is what causes people to present. So they're very, very sick people. It is a really significant illness, invasive meningococcal disease, and it has an overall mortality of around about 8%. The majority of deaths occur within 24 hours of them becoming unwell. So it's a really rapid disease process. Main presentations, like I said, meningitis and sepsis. The problem with meningococcal disease is that most people that present early in the disease process present in with fairly non-specific symptoms. You know, they feel a bit tired, they've got a bit of a fever. Maybe if it's a child, they're just a little bit anorexic, they're just a bit fussy with the food. They might have a headache. Some people might have some nausea and vomiting. Certainly, if they complain of cold or discoloured extremities, that seems to be something that's quite common and can be picked up. They might just feel a bit achy. So almost all of those symptoms, you would be thinking somebody's just coming down with a viral illness, you know, potentially a flu. So it's very, very easy for clinicians to not diagnose meningococcal disease on the first presentation. So absolutely crucial that the information that is sent home with these individuals is, please watch this person closely. If they deteriorate, bring them back immediately or take them immediately to an emergency department. Watch them, watch for any spots, watch for a fever, see if they're becoming confused, etc. So it is difficult for clinicians to diagnose this disease immediately, particularly if the person has coming in with those early symptoms. Around about 95 to 99% of children that present with fever and petechiae will have actually another infection rather than a meningococcal infection. So we've just got to be a little bit suspicious, and certainly if you are sending people home, then give them some really good information to go home. These individuals do become unwell very quickly. In regards to the disease process itself, incubation periods are around about 3 to 4 days, but can vary around 1 to 7 days. Yeah, occasionally it might get pushed out to 10 days, but rarely. People are infectious for as long as the bacteria are present in the nose and throat, and they do respond very quickly to antibiotics. So if the appropriate antibiotic is given, that bacteria disappears around about within 24 hours. Appropriate antibiotic treatment is absolutely crucial. So if there is any clinical suspicion that this person might have meningococcal disease, you are better off drawing some blood at the very least and giving a dose of an appropriate antibiotics. So obviously, if you are in a hospital and you've got the ability to take some spinal fluid, then that's even better, but definitely a blood test. So there is meningococcal treatment guidelines. So your medical officers should be very, very familiar with those and be selecting the correct antibiotic to be given. But, you know, this disease has been described as the most rapidly lethal infectious disease known to man. So we do need to really think about sending anybody home that's coming in with these sorts of symptoms. So like we said, if you look at this particular list, it really could look like a cold or a flu. It might look like gastro. It might even look like a hangover if you're dealing with a teenager that's just been partying. So it is really difficult to diagnose, but certainly those, you know, the red flags is that, you know, for that early sepsis, most people, particularly children, will complain of limb pain, but it's this cold hands and feet or this pale or mottled skin are some fairly early signs that sepsis is setting in. So that bleeding under the skin, you know, people talk about the meningococcal rash. This generally is a fairly late stage of the disease, and we would certainly hope that this person has been diagnosed and at least received some antibiotics before the rash appears. So the rash is really when the bacteria have multiplied in the blood vessels. The toxins that they release will damage the blood vessels, and then the blood leaks out into the tissues that are underneath the skin. Hence you get that purple, that bleeding under the skin. This rash may start off as absolute little pinpricks, and it might be in the hairline. So you've really got to examine people completely all over. It might be palms of their hands, soles of their feet. It may not be really, really obvious on their chest or tummy, but we certainly know that once they start, they will just appear before your eyes. And they will become more than a pinprick, they become quite blotchy. So the person can really go into shock at this stage, and their blood pressure will fall, circulation fails in the extremities, and of course once you get that death of tissue through lack of blood supply, then you're looking at amputations, particularly of digits or limbs, or most definitely this might result in death. The rash can be really, really hard to see on dark skin, but clearly making sure that you do check feet, palms of hands, etc., to see, particularly if somebody has shown some of those other symptoms for sure. There is talk about a test that you can do with a glass. So if you get a glass out of your cupboard and press it against these spots, if it is a bleed under the skin, then it won't blanch away. But if it's just a spot of some other description and you press a glass against it, it should blanch away and go quite white. But we don't want people waiting around for a rash to appear, because like I said, it may never appear, but it is a late appearance in the disease process when it does appear. So we definitely want to get in and get these people seen much earlier in the disease process. So if you were just listening, I've answered the question for you. Is a rash always present in people with meningococcal disease?
And I've launched the poll for those of you who'd like to answer on the screen. Okay, they were listening, Angela, just so you know.
Fantastic.
We have 97% of people who have answered, which is over 100 people now, are saying no.
Excellent. Thanks, Susie.
Okay.
So definitely we would not wait for a rash to appear. It is one of the later stages of symptoms, but certainly if this person, or if it's your child or your teenager that you've taken to hospital, don't let doctors or hospital staff assume that because they don't have a rash, it can't be meningococcal disease. Some people really need to be persistent and say, no, 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 they are really unwell. They really are unwell. Please, 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 think about meningococcal disease. Oh, Susie, can I move on?
You should be able to. I have got a backup here if you can't. Maybe go backwards and then forwards again like we did last time.
Not doing anything at all, actually, my buttons. So let's just go up.
You love technology.
Oh, gotta love it, don't you? And I'm just trying to see where I can change my slides.
We have had this problem once before, I recall, and it may have been that you had to unshare. Oh, you've done it.
I've done it. There it is.
You've done
okay.
it. Look, well done.
See, I don't know what I did, everybody, but you know, I'm clearly.
Thanks for your patience.
Thanks for your patience. I'm clearly an IT whiz. Okay. Symptoms in babies. Look, they may not have those classical symptoms. Once again, they may just get fussy. They may have a little fever, they may have a big fever, but really easy to misdiagnose. Think about the level of parent concern. If there's if there are people here that know their own baby, it's the parents themselves, and they will be able to say they've never been this sick before. Yes, she's had colds before, but she's never been this sick before. So these perceptions of parents need to be taken really, really seriously. There was a really large UK study that found that about 50% of children presenting to GPs with meningococcal disease were actually sent home on their first visit. And unfortunately, these children were more likely to die. So parents do need to go home with information about watch their fever, watch for a rash, watch for any deterioration, and certainly bring them back, get a second opinion if they continue to worry, be worried about this little baby. So complications can be really significant from invasive meningococcal disease. Some people can survive meningococcal disease unscathed. They have no long-term sequelae, but others, it can be quite life-changing for them. So complications of meningitis, septicemia, lung infections, brain damage, skin scarring, really quite significant for children, adolescents and adults. So we talked about that progression of sepsis. But, sepsis really is known as septicemia or blood poisoning. You may have heard it, it's a bit of an old-fashioned term, really. We tend to use septicemia. But the septicemia really does lead to tissue damage, multi-organ failure, and of course death. And we do know that skin petechiae, is that first visible evidence that there is this micro-bleeding that's, associated with, disseminated intravascular coagulation, or DIC as we refer to it. But these toxins that are released can really damage heart muscle. They cause, cardiorespiratory failures. Pneumonia is also something that we can see with invasive meningococcal disease, and definitely kidney damage or renal failure. Some of these people do end up on, dialysis after they recover from this particular disease. So we do want to get in early before this sets in. So we talked a little bit earlier around the different age groups, and there does seem to be some commonality, and it is children under 2 years of age and adolescents that do tend to be the highest risk groups. But bear in mind, whilst we can sort of say, look, these are the saliva sharing age groups, the little ones are, certainly doing a lot of dribbling and putting things in their mouth and sharing them around. Our adolescents are playing tonsil hockey or whatever they are out there. But we do see invasive meningococcal disease across other age groups as well. So we can't be just thinking because somebody's 69 years of age that this presentation may not be meningococcal disease. So there are some risk factors in regards to people that are at increased risk of invasive meningococcal disease. There are certain immune deficiencies, and particularly hematopoietic stem cell transplant. Patients do require additional vaccines. There's certain medical treatments, and, particularly, the drugs that are used for, really significant immunocompromise. So they may well be required to have meningococcal vaccines prior to their treatment starting. So please make sure that you do speak to the appropriate specialists to make sure that people are vaccinated according to the patient's diagnosis. Other risk factors: exposure to cigarette smoke or being a current smoker, certainly being in dormitory style accommodation or very close quarters. So certainly consider vaccination for your patients that have these particular risk factors. You know, with the cigarette smoking, if you do have family, friends that are cigarette smokers, you know, we're leading up to meningococcal season as we speak. So this is just a really great opportunity for people to give up smoking, and definitely for adults not to smoke around young children. I know you're all stressing and people may not be coping well with isolation, and you probably don't want your partner giving up smoking while you're having to live so closely to them. But it's certainly a good idea from a meningococcal disease point of view. So disease rates sort of decreased there for a little while, and then they've bounced around, and we saw this on the previous slide. But we've got a really great meningococcal ACWY program now, and that really is going to really demonstrate to us that we can control these sorts of diseases. Unfortunately, we don't have a nationally funded meningococcal B program. Meningococcal B has remained as a dominant strain. Its rates are still, you know, quite reasonable, and they don't really bounce around. If you were to look at the graph, you know, they just are fairly stable and fairly high. Aboriginal and Torres Strait Islander people are certainly at risk of this, and you know, there's certainly some consideration to whether or not the vaccine should be at least funded for those particular people. South Australia, of course, if we've got any South Australian providers on board, we're very, very fortunate in the fact that we have been given this opportunity of a funded vaccine program. We've had a catch-up program for children as well as teenagers, which ended at the end of last year. But we still have an ongoing program for children. So we vaccinate babies at 6 weeks and 4 months of age, and then another dose at 12 months. And we also vaccinate our adolescents in the Year 10 school program. We did do a major study over 2 years here, which was called the Be Part of It study, where the beautiful vaccinators went into schools. They throat swabbed students and vaccinated them. And then in the other schools, those particular students just got a throat swab in the first year, and then they got vaccinated in the second year. So that particular study didn't demonstrate what we were hoping to demonstrate, which was that there was carriage. And by vaccinating people, it reduced the carriage rates, and it didn't do that. But what it did do was prove that this vaccine is very, very effective, because none of those students have had meningococcal disease. And we will talk about the comparison of other years in that particular age group a bit later.
Now, Angela, there is a question from somebody just asking if you know any further about why the Men-B vaccination isn't part of the NIP, that you might have some information there.
Look, you know, it's an expensive vaccine, and when governments are making decisions around what vaccines should or should not be funded on the vaccine program, they need to have really good evidence of broad protection across the community. And what we do know with this particular vaccine is that It didn't reduce carriage, so we still know people are out there carrying it, but it does give that individual's protection. But there is some considerations being made by Commonwealth, so it is a little bit of a watch, wait and see at the moment.
That's great news. Thank you.
So if we look at this particular graph, this is really talking about the months of the year that meningococcal disease is most prevalent. And you can see those little peaks, and then you can see the troughs. So we are certainly, starting to look at, sort of May, June, July, it is going to start to climb. Some years we have meningococcal disease more broadly across the year, but certainly you can see that big spike in 2017. But looking at the colours, that red colour is meningococcal B notifications. So you can really see that, whilst there's a little bit of movement up and down, it's relatively consistent right across the month and years of diagnosis. So definitely, like I said, May, we probably start to see our cases through until around about September, and that's when they'll start to decline again. Once again, if we're looking at notification of disease, we can definitely see those red bars once again are representing meningococcal B disease. If you look at the green bars, back in 2002, there are cases of meningococcal C. The vaccine program was introduced in 2003, and you can see how successful that vaccine program has been. So for anybody that does query, do vaccines work? I think this is exceptionally good evidence that we can say that yes, they do.
And do we know much about how long they last in the system once the vaccination's been given?
Yeah, look, this is an ongoing thing. Meningococcal vaccines haven't been around for a really, really long time, but we know that so far there is good coverage. And if we're looking at meningococcal B vaccines, that there's certainly good coverage out to sort of 3 to 5 years. So it's looking at the type of vaccines that we have for ACWY and for meningococcal B. The way they work on the immune system is exceptionally positive that there will be long-term protection, but how long that protection is, we don't really know yet.
Okay, thank you very much.
So if we're looking at deaths from invasive meningococcal disease, numbers are thankfully not high, but any death from a vaccine-preventable disease is one death too many. So it is really good that we are able to recognise this disease and certainly get that antibiotic treatment started very, very early. So if we look at prevalence across the states and territories, you can read that slide quite well all by yourselves, but clearly we've got higher rates of disease in certain states and territories, certainly the most populated states. So we're looking at New South Wales and Queensland. Probably Victoria, it's a populated state that does, really reasonably okay, but numbers are still there. For South Australia, we have reasonable numbers, but look at our cases of meningococcal B in comparison to the other serotypes. So South Australia was the prime location to be doing the B part of its study and looking at carriage rates, because getting these vaccines into our population were really, really important, because most of our cases are meningococcal B serotype. So this is 2019 data. It's quite difficult really to get data that's right here, right now. We need to rely on publications. So this was the data from 2019, and you can see once again those states that had higher disease than other states and territories. If we're looking at particular age groups in regards to meningococcal disease, we can very clearly see that those children under 4 years of age have really quite significant disease. And if we're looking at children less than 1 year of age, this is why South Australia has introduced this vaccine at 6 weeks of age, rather than waiting until the child is 12 months or 2 years or 4 years of age. So really important that parents do take this opportunity to receive these 3 doses of vaccine free from our state government. But certainly for other states and territories that do not have a funded meningococcal B program, it's still a vaccine definitely to talk to your parents about. Use the information from these graphs to alert parents to the fact that this disease is prevalent in these very, very young babies, and perhaps to consider buying the vaccine on private prescription. If we look across the other age groups, once again, we get that peak around about those teenage, young adolescent, young adult type age groups. But we still see some cases right across the age spectrum. So prevention always better than the cure is what we say. And definitely we have a number of vaccines that we're going to be talking about. So clearly quadrivalent ACWY conjugate vaccines. So we have 3 of them that are registered for use here in Australia. The most common ones that are probably really favoured are Nimenrix and Menveo. Menactra can be used, but from a later age range. And there is an issue with co-administration of Menactra with Prevnar 13. The recommendation is that if you are using Menactra and the child also needs Prevnar 13, really try and get another ACWY vaccine, because there is that possible interference of the immune response to some of the pneumococcal serotypes. If you can't avoid using Menactra, give the Prevnar 13 first, and then 4 weeks later, give the Menactra. If you happen to co-administer them inadvertently, don't worry too much about it. You don't need to repeat either of the vaccines. If the person also needs Menactra and a diphtheria toxoid containing vaccine, once again, it is preferred that you would use Nimenrix or Menveo if you can. Once again, if co-administration with Menactra and the diphtheria toxoid vaccine has to happen, then certainly go ahead, but it could cause an interference. And it's actually the other way around this time. It's the diphtheria toxoid that may interfere with the immune response against some of the meningococcal serotypes. So have a little think about the vaccines that you're using, and once again, we always stress that providers should know what they're giving, why they're giving it, how they're giving it, to whom they're giving it, and when are they giving it. So always ask yourself those 5 points before you immunise. Nimenrix and a tetanus-containing vaccine should be co-administered rather than separated out. They would be better off being co-administered on the same day. If Nimenrix is administered after a tetanus-containing vaccine, it might interfere with the immune response from some of those meningococcal serotypes. However, there's quite a lot of uncertainty around that, and therefore, if Nimenrix is scheduled to be given, even if it's being given shortly after a vaccine that's containing tetanus toxoid, then just go ahead and still give it, because really the jury's out on that interference. So we are probably not finding much Neisseria around. You might have some in your fridge for catch-up programs, but most of the time it's now Nimenrix that you'll be using. You probably are not using Meningitidis at all in your fridges. And of course, your meningococcal B vaccines, you do have a choice of two, but it's only Bexsero that we can use in the babies and the young children, and Nutrimember is from 10 years of age only.
And Angela, just someone's asking you just to repeat, Pneumovax 12 or Menectra, which to give first? I think they may have missed your comment on that. Yeah.
So if you're doing Menectra and Prevnar 13, not your Pneumovax 23, so this is just
okay.
13. Okay. There is that possible interference with the immune response to the pneumococcal serotype. So give the Prevnar 13 first, followed 4 weeks later by the Menectra, or use another ACWY vaccine would be even more preferable.
Great, thank you. And another quick question on availability of the quadrivalents in the private markets for those who are not under a vaccination program. So say migrants, for example.
Yeah, look, I'm not aware that there's a shortage of ACWY vaccine on the private market. If anybody else is on the webinar that could...
Yeah, they can just pop that in the chat box, that'd be fine.
If they know anything different, but I have not heard of a shortage myself.
No worries. Great, and I can launch the poll when you're ready.
Lovely. So our second poll is, how are Menveo and Nimenrix vaccines administered to the patient? So if you've been giving these vaccines, you will know the answer very, very easily. Is it in liquid form and you simply just draw it up and give it? Does it consist of a powder and a liquid that you've got to reconstitute? Is it oral? Are they best administered 2 months after other vaccines have been given?
So we've got about 50% of people who have voted. We'll give them a couple more moments before we reveal where people are voting. 60%. Feel free to pop your vote in now. Have a go. All right, I think we're slowing down now. So we have probably 70% of folks saying B is correct, powder and liquid, and a few others have gone more towards your A option.
Sure, okay. So B is the correct answer. Your Menveo, the meningococcal A component is the lyophilized powder that is in the vial, and there's an accompanying syringe that contains the meningococcal C, W, and Y antigens. Your Nimenrix is a white powder that's reconstituted with normal saline. So both of them are a powder, but they're reconstituted with different diluents.
And just to clarify, we've had someone answer our question. Thanks, Jessica from Pfizer. Nimenrix is available on private prescription.
Ah, lovely. Thank you very much.
Good teamwork.
Good teamwork. Okay, so who should be vaccinated? Well, a whole range of people, to be really quite honest. We want to make sure that we're giving the right vaccine to the right age group of people. If you are giving Menactra also, the PI for Menactra states that the upper limit for people to receive that vaccine is 55 years of age, but ATAGI, the Australian Technical Advisory Group on Immunisation, recommends that these vaccines can actually be given to people over 55 years of age. So when you're giving private prescription vaccines, you will probably find that, you know, you've got your product information sheet that's in the box. So please make sure that you're accessing the information from the online immunisation handbook and look under variations from product information. So the companies are required to put in those product information sheets with their clinical trial data. But sometimes ATAGI will override that clinical trial data from the vaccine company based on looking at other evidence. So please always follow those recommendations in the immunisation handbook. Menveo and Nimenrix don't have upper age limits, so you can certainly be offering that particular vaccine. Men B and Men A and Men ACWY are recommended really for all adolescents 15 to 19 years and people with chronic medical conditions that increase their risk of invasive meningococcal disease. Laboratory workers that are frequently handling these particular specimens, anybody that's a young adult that's living in, you know, really close quarters, like we were talking about, you know, seeing before, military recruits, etc. And particularly if they are current smokers, really important. We know that we've got Nimenrix, meningococcal ACWY available on the nationally funded immunisation program for adolescents, generally given in around about the year 10 school program level. If people are outside of those funded age groups, then they would need to purchase it. However, people under the age of 20, so up until the 20th birthday, if they require catch-up ACWY vaccine under the no jab, no pay, you would be probably giving that vaccine. And you might find on some of your parents that are coming in with a report from Centrelink to say that their teenager is not up to date, but the individual has actually had a meningococcal ACWY vaccine previously. Just double check, it may well have been a polysaccharide ACWY vaccine, not the conjugate ACWY. So if they've had a polysaccharide ACWY previously for travel or whatever reason, please give them a conjugate ACWY, and that would be your Nimenrix funded. So we have another poll.
Okay, and here we go. It's been launched.
So you have a 5-year-old present to your clinic for some catch-up vaccinations, and you note that the child received Meningococcal vaccine at 12 months of age. So would you offer a dose of meningococcal ACWY to this child? Yes, because it's on the funded program, or no, because it's not funded, or yes, but on a private prescription.
Okay, about 30% of people. Currently, we've got an even split between two of the responses.
Mm-hmm.
Let's give you 5 or 10 more seconds. Okay, 70%-ish have now responded, and we have an even split with C, yes, but on private prescription, slightly winning over A.
Okay, very good. Okay, so the ground rules are that if a child has received a Meningococcal, so that's a HIP and Men-C combination vaccine at 12 months of age, they are not eligible for a catch-up ACWY vaccine. So you would definitely be talking to these parents about the benefit of them having an ACWY vaccine, but it would be on private prescription.
And just a quick comment on private health cover. If you do have it, it is worth checking rebate for immunisation if getting on a private script.
Absolutely, and same goes for any private script vaccine. Most private insurance companies will rebate a portion of the vaccine cost back, depending on the company that you're with. So absolutely worthwhile. But unfortunately, they're not PBS listed. So if people do not have private health cover, then they will be having to pay full price.
Yes, correct.
So ACWI, we talked about the funded program. All children have a dose of this vaccine at 12 months of age, and that program started on the 1st of July 2018. So we're almost a couple of years into it now. And of course, we do have our adolescent program in the school program as well. So it's going to be very interesting to watch this particular program and see the success, and there will be success for sure. Our meningococcal B vaccines, we've already discussed sort of the risk factors and the risk individuals, but certainly offer this vaccine if you are not in South Australia, clearly, but for other states and territories, please offer this vaccine on a prescription to parents. Use the data, like I said, out of the slides here. You can Google them, you know, this type of data, and use that to talk to your parents about the risk of meningococcal B disease in those very, very young children.
Okay, and Angela, do you have any idea of the approximate costs that the vaccination would be if it's not covered?
Yeah, so meningococcal B vaccine, generally as a wholesale price, it's around about $110 per dose. Depends on how many doses the child needs, depends on what age they actually start the vaccine program. So check the schedule that's in the immunisation handbook for that. But look, shop around. I always say to people, let your fingers do the walking, phone around 6 or 7 different pharmacies. You'll get 6 or 7 different prices. Go with the cheapest. It's exactly the same vaccine, doesn't matter. So pharmacies can mark up whatever they like to whatever they like. So definitely shop around.
Good advice, thank you. Launching poll number 4.
Good. Okay, so we do vaccinate pregnant women with certain vaccines. Would you vaccinate a pregnant woman against meningococcal disease? Yes, because meningococcal B should be given between 28 and 32 weeks, or they should get a 4-valent meningococcal conjugate vaccine at 28 to 32, or we should be giving them just a meningococcal C conjugate vaccine between 28 and 32, or meningococcal vaccines are not usually recommended for pregnant women.
And it is pretty adamant from the 70-odd% who have now voted. We have 98% of them saying D.
Absolutely. We know what they're doing out there for sure. We can't trick them.
That's right. Thank you.
Perfect. Okay, we're quickly looking at vaccine effectiveness. You know, we will see some really good data coming out in, you know, certainly the next couple of years. But what we do know from other countries that have used the 4-valent meningococcal conjugate vaccine, so the ACWI conjugate vaccine, that vaccine effectiveness is estimated around about 80 to 85%. So really important that providers are really transparent with information when we vaccinate, that we must talk about the possibility that even though somebody's having a vaccine, there is still a risk that may still contract disease, because very few of our vaccines that we can say are 100% effective in 100% of the people that we give them to. But this vaccine is a really, really good vaccine. So good efficacy, but we must really advise people about signs and symptoms of meningococcal disease, even though we're vaccinating against meningococcal disease. So our conjugate C vaccines we were using from 2003 resulted in that massive reduction of meningococcal C disease, 96%. So we know that these vaccines are very effective at reducing disease. So we really need to keep our vaccination rates high. So definitely talk to parents around meningococcal disease and what vaccines are available to them. If there's one thing that we do hear quite commonly from parents whose children do contract meningococcal disease was, well, I never knew there was a vaccine, or I've never been told by my provider that I could have had her vaccinated. So please make it a regular conversation. So meningococcal B vaccine, once again, excellent vaccine, gives high protection, protective antibody levels. So it should be really noted that, you know, the meningococcal B vaccine can't really be expected to provide protection against all circulating meningococcal B strains. Unfortunately, there's lots of different strains, but certainly the vaccine that has become available to us is a very, very good vaccine. So with the Men-B part of it study in South Australia, that ran between, you know, for 2017 and 2018, and there was about 35,000 high school students that participated in that particular study. And whilst it didn't demonstrate reduction in carriage, it really demonstrated that it afforded a high level of protection amongst all of those students, as there wasn't any cases of meningococcal disease in that age group during the 3 years of that overflow study, because there was an extra overflow year, compared with 12 cases of invasive meningococcal disease in that same age group in the previous 2 years. So it's really very, very good evidence that people are definitely protected against this particular disease if they're vaccinated. Obviously, adverse events, as with any medication, there may well be some adverse events. Most of them are very, very minor. It is a very safe and very well-tolerated vaccine. The product information for Menactra states that if that a previous episode of Guillain-Barré syndrome is a contraindication. However, ATAGI recommends that a person with a history of GBS can be administered any of the conjugate ACWY vaccines, but certainly all risks and benefits should be explained to every client prior to vaccination. So obviously with the meningococcal B vaccine, fever is probably the biggest issue, particularly in the little children, and so ATAGI does recommend that prophylactic use of paracetamol with every dose of meningococcal B vaccine administered to children less than 2 years of age. So there is that risk of fever, so please talk to your parents about how to look for a fever and how to manage a fever, and to seek medical attention if they are concerned. Definitely that first dose of paracetamol should be given within 30 minutes prior to vaccination, or if they haven't had it, you can still vaccinate and just ask the parent to dose the child as soon as possible afterwards. This should be followed by 2 or more doses of paracetamol, 6 hours apart, regardless of whether fever is present or not. Obviously, as with all vaccines, the true contraindication is anaphylaxis to a previous dose or anaphylaxis to a component that is in the vaccine. If somebody's had previous meningococcal disease, regardless of the serotype, that is not a contraindication for receiving the vaccine. Obviously, This disease is notifiable in all states and territories. We talked about how prompt a diagnosis and treatment is if we want to successfully treat this particular individual. So please be aware of the invasive meningococcal disease national guidelines for public health units. That will talk about the process, what is the clinical criteria, and what are the treatment options available. So just really quickly, we are watching, and the experts are certainly watching what meningococcal serotype W does. It is a very hyper-virulent strain, so it's a funny presentation, quite often gastrointestinal presentation initially, but certainly that's that rapid onset of sepsis. We know that there are people that do die from this disease. Some will survive, but with long-term sequelae, but others will survive with no long-term sequelae at all. So definitely, we know the disease will progress rapidly. Please make sure people are aware of the signs and symptoms and to be really vigilant as well. And really promote these vaccines, both ACWY on the private market as well as meningococcal B vaccines.
Fantastic. Thank you so much, Angela. Once again, amazing presentation.
Thank you for having me, and I hope everybody has walked away with just one new bit of knowledge. That's all I aim for.
We've got a smart crowd in there today. There are a few questions left over in the Q&A section. I am cognizant of time. Do you have a couple of minutes just to very briefly cover one or two of them?
Yep.
Okay. Katie's asking again how long the cover lasts for the Men B vaccine.
Yeah, so once again, you know, the vaccine hasn't been around for a really long time. Is someone's on here from GSK?
There's no comments coming through at this stage. I'll have a look at the chat.
Yeah.
Thank you for, okay, no, there's lots of thank yous and your wonderfuls.
Yeah.
All right, let's move on. We'll leave that one for now. The last one is, I think you may have answered this one as well. The 5-year-old has, if they have a quadrivalent, do they have another one in their teens?
Look, this is going to be a bit of a watch, wait and see to what the program does. As we know, our program changes almost annually. So a lot of this will depend on the data that comes out in regards to how long the vaccine antibodies do last and and what protective level they need to be at.
Yes.
So that's a bit of a watch, wait and see.
Yes, okay.
I can't really say what it will be.
That's fine. Thanks so much for those, Angela. Unfortunately, we don't have time this evening for any more of those questions, but as I did say at the beginning, please feel free to email me at Immunisation Coalition. That's Susie at immunisationcoalition.org.au. I will make sure I respond to those answers as soon as possible. Also, a recording of this webinar will be uploaded to the Immunisation Coalition website in the next week or so. And once again, we'd like to really thank you all. We've had a great turnout this evening. Angela, as usual, thanks again. And we hope to see you next time in July. We will inform you of our next webinar event.
Excellent. Thank you, Susie. Stay safe, everyone.
Thanks so much.
Okay, good night.
Stay safe. Good night.
Bye.